We have two cases. We don't know how much we'll complete. Both the cases were recently managed by us in our institute. So we'll see how the experts help us managing the two cases. The first case was a 4-year-old male who had moderate global development delay. He had received blood transfusion 1 year back, and he had history of jaundice, diagnosed as hepatitis A 2 months back. The current history dates about 12 to 15 days, which has been running fever. He was treated at Hyderabad and later at Nanded. There the investigations of CBC, HIV, cultures all were negative. He's received 1 pack cell transfusion for his anemia. In Nanded, inflammatory markers were positive. They were suspecting hemophagocytic lymphohistiocytosis. They put on a second line of antibiotics and steroids, and the patient has been referred to us. At our hospital, about 15 days of fever was there already, and he had, on examination, vitals normal. He had pallor, he was conscious, malnourished, there were contractures, he was like a cerebral palsy, very irritable child. He had a liver of 3 centimeters and a spleen of 2 centimeters. Rest of the systemic examination was normal. The basic workup included CBC was okay. He had pallor. Platelet count on 1 occasion was normal, was low. His liver functions, renal functions were normal. Serum protein was okay. Urine and stool examination was all right. ESR was 33. The basic workup for infections and fevers, X-ray chest, urine, malaria, lepto, dengue were negative. The cultures in the first week was negative. His Vidal was negative, and blood transfusion, as we said, was given for the patient. Now, Dr. Balasubramaniam, considering the diagnosis of typhoid or whatever this patient has come through, just name the antibiotics you will probably give this child, if you want to give, or you want to wait for some more days before you evaluate, or you want to give, which antibiotics will you give? We'll discuss the antibiotics later on.
Well, let me tell you, with the background like this, I don't think I have a guts to withhold antibiotics.
Yeah.
There is a patient who's ill, who's been having fever for quite some time, with the hematological abnormalities with the background of transfusion. There are two things which need to be kept in mind. One is if you have this sort of hematological manifestation occurring very early in the course of the disease, typhoid is very, very unlikely. Typhoid manifesting with hematological manifestation first few days, it's for 3, 4 days, 5 days. That's very, very unusual.
No, it's nearly a 3rd week of fever.
Yeah, and then that's one. Second thing is, if you have given good antibiotics, you should look beyond typhoid or a complication of typhoid. That's number 2. Number 3 is that
we'll come to the differential later on. You will antibiotics will
before we start antibiotic, you must know what we are dealing with.
Yeah.
I don't think I would give antibiotic.
So that you give the answer later on.
Yeah, it's very difficult to give an answer straight away. And before I give antibiotic, I'll go through what is the possibility. One, is this infection or is this an infection related hematological complication? That's one. And third, this is a non-infectious disorder. But in the background of this, definitely yes, this child is likely to have infection with a hematological complication. Infection is unlikely to be typhoid. It is likely to be a non-typhoidal illness, and unlikely to be a gram-negative sepsis or an endotoxin shock or anything.
So
a septic
choice
shock
of antibiotics?
Unlikely. Choice of antibiotic, definitely I would give a broad spectrum antibiotic to cover possibility of typhoid. Again, it can be uncommonly present like this. Definitely, I would cover atypical organisms with doxycycline. Certainly for this
you'll
child.
give only doxycycline.
Not only doxycycline. Ceftriaxone with doxycycline.
Fine.
The child has not received
Okay,
anything.
fine.
Now the mantra is, if you have a child who has 7 days fever in whom you suspect typhoid, now typhus is quite common. And to cover atypicals, including tularemia and other things, better to start doxycycline before you get the diagnosis.
Okay, fine.
At this point
go
of time.
through the
But
next
then
case.
I would think beyond infection in this child.
Correct. So now we'll talk about typhoid, because it was the first thing we consider when the patient has fever for 5-7 days. So as per the current sensitivity in your institute and the current literature, Dr. Balasubramaniam, what are the optimal choices of antibiotics and empiric therapy for a seriously ill admitted patient and outpatient patient? Which one will you select as a first line therapy for typhoid fever?
Before we look at the optimal choice, we look at the current sensitivity. Current sensitivity, most strains are sensitive to cephalosporin. In fact, there is a recent data from Bangalore as part of surveillance, and from our own data, 98% of the strains are sensitive to 3rd generation cephalosporin. That's number 1. almost 80% are nalidixic acid resistant.
Yeah.
And we have started doing azithromycin sensitivity, and we are checking the MIC. It's still pretty low. In about 20 cases we have done so far. And so we do not use quinolones as a first drug. That's number one. Though the WHO continues to recommend quinolone as a first drug, we do not use. Our choice is between a third generation cephalosporin and an azithromycin. Yeah. If the patient is non-toxic, we continue to use cefixime 20 milligram per kg. In case there is reluctance on the part of parents to give twice daily, might be I would prefer to use azithromycin, particularly if it's an older child, 20 milligram per kg for 7 days. Toxic child, ceftriaxone 75 to 100 is still good enough.
And then you switch over to cefixime after that? After 4-5 days?
There is no data on the validity of the switch therapy. I mean, principles of escalating and de-escalating suggest that you can give ceftriaxone and change out to cefixime, just like any other serious infection like pyelonephritis or pneumonia. We can give inpatient ceftriaxone for as many days as needed, then switch out to cefixime to complete probably 14 days of therapy.
Dr. Ira Shah, what about combination therapy you used any time in patients of typhoid fever, or you just stick to monotherapy?
Ideal would be monotherapy. So you would start with ceftriaxone.
What about the duration of treatment? You will give minimum, and up to what days you give therapy?
See, usually when we are treating enteric fever, we try to even eradicate the carrier stage. So if we are using cefixime, you may need to give it for 14 days. If you're using ceftriaxone, it's not necessary to give it for 14 days. Once the fever subsides, you may switch over to oral, but the total duration should be 14 days.
Yeah, minimum 14, because 7 days and all, there are high chances of relapse, and you should at least wait for 5-7 days.
Except for azithromycin, where you're using azithromycin. Azithromycin has a long half-life.
Tissue levels are maintained.
Yeah, so it will be in your system for a very long time. So you could get away with 7 days of azithro.
What about steroids, Dr. Ira Shah? You've used it any time? You want to comment on steroids?
Can I ask the audience, is there anybody who has not used a combination of drugs for typhoid in the audience?
I think we'll come back to later. We'll have to finish
just ask this question. Is there anybody who has not used a combination of drugs for typhoid in this audience?
Yeah, very good.
Yeah, that's a minority, that's a fact. But then combination is rarely required, is not at all required. Unless you have a diagnostic doubt, in which case you use some other drug. For, as I said, sometimes we use azithromycin or doxycycline if we suspect an atypical organism in addition to ceftriaxone. For typhoid alone, there is absolutely no indication for using more than one drug, provided your lab gives you a good sensitivity report. With regard to steroids, steroids again are not indicated routinely in any non-sick patient with typhoid fever. 1. 2. There have been good studies from Indonesia and South Africa where they have used high-dose dexamethasone, very high doses. I don't want to mention here. They mention for endotoxin shock, myocarditis, stupor, coma, something like 3 milligram per kg every 6 hours, very high doses. It is recommended only for 48 hours, and that is not needed in most practical situations in practice. The only other indication available in literature is that some children with typhoid may continue to have what is called systemic inflammatory response, for which Pakistan pediatrician Bhutta has suggested that may be increased levels of interleukin, almost similar to a mild form of HLH, in which case a short course of steroid may be considered, but that is not often required in day-to-day practice.
I think unless it is culture proven and you're sure the patient is very ill, then only you use steroids. Typhoid fever generally is diagnosed clinically and the culture method, but culture is not always available to us everywhere unless you're in major institutes, and it's only positive after the first week only in 50% of cases. Other than this, what are the other tests within the market which are available for us for rapid diagnosis? Because there are a lot of tests which are being used.
The one which we are familiar with in our hospital, in fact, my own colleague has published it in a journal about the validity of the IgM ELISA test. It's quite a useful test. The only difference between that and the Vidal is that Vidal helps you only after 1 week. In the first 3 to 7 days of your 4th day fever, you are awaiting culture. The IgM ELISA, if done properly with a good kit, has a specificity of almost 80% and a sensitivity of around probably higher about 90%. The disadvantage is that You have to do only in a short window period of 3 to 7. If you do it very early, you may not pick it up. If you do it beyond 6, 7 days, you may not pick it up. By and large, we don't go by that. We go by our clinical judgment.
Yeah.
In fact, if your lab can't grow Salmonella typhi, that lab should be closed.
Yeah, it's quite easy to grow Salmonella. So we'll go to the next part.
And PCR is coming up in a big way. We'll
Yeah.
be using it and misusing it very soon.
So we had given this patient ceftriaxone, amikacin, and considering Ira's talk, we also tried our luck at doxycycline. The patient responds, and probably you don't have to work up the patient further. However, the patient did not respond for 7 to 8 days. I just want to give you all to give 2 to 3 possible diagnoses. Sir has already mentioned, you can mention 2 to 3 possible diagnoses in this. Only the clinical diagnosis, don't mention anything else. We have shortage of time.
In this child, you have a child who is bedridden. He's a cerebral palsy. He's got hepatosplenomegaly. So there's no question of travel or animal exposure. He's got a hepatosplenomegaly. A bedridden child is very prone to get pneumonia, very prone to get tuberculosis. Your bedridden child who's landed up with hepatosplenomegaly, anemia, requiring a blood transfusion. If we are going to talk about infective causes, the first thing that comes to my mind is tuberculosis.
Yes.
And which kind of TB is going to land up with anemia and a hepatosplenomegaly? A disseminated TB is not going to cause anemia. Anemia in a TB means bone marrow involvement, means Mycobacterium avium to me.
Okay, so you will consider tuberculosis. Anything else? One other diagnosis?
So you would definitely consider tuberculosis. You would consider non-infective causes of fever.
Like
so you would
one
keep
cause.
Malignancy would be.
Okay, fine. So I think we'll go through there's a long list.
I also think of an abnormal host with the usual infection.
Correct.
Which is not responding to standard.
Yeah, so there's a long list
I
of
feel
all
I'm sitting in a
pediatricians.
viva. One answer.
No, because we have to run through the pediatricians normally run through all these things. They do all the investigations, so we are not going to run through all these things. Fever still persisted. Second week, the blood cultures came coagulase negative staph. Blood fungal was negative, HIV was negative, rickettsial test were negative, tuberculosis workup was negative. The HLH repeat testing was not contributory. So Dr. Ira Shah, what is the significance of a coagulase negative staph on culture in this patient?
Not really significant because cons is a usual pathogen of the skin flora. So if you get cons on a culture, it could just be a contaminant.
Yes.
If
you get 2 to 3 cultures positive, then it is
you
significant.
would consider this in an immunocompromised
or a
child,
catheter.
Yeah, child in the ICU.
So we still had to do something about it. We'll see that later on. He's malnourished.
Yeah, but you need
No, but one culture of coagulase negative, you should get 2 or at least 2 cultures with coagulase negative. You can treat it. Most of the pediatrician will treat it. Let's go ahead. We'll
when you
discuss
talk about
this.
immunocompromised, you want somebody with lines inside when you talk about cons.
I'll worry about cons in 2 or 3 situations. One, my microbiologist calls me within 24 hours that cons is growing. I'll be definitely worried. 2, if the patient is simultaneously sick and toxic and septicemic, with an early report, I'll worry. 3, the patient who has a catheter, cons 24 hours, definitely I will not ignore that. I will treat, of course, reinvestigate 2 or 3 cultures.
Okay, sorry. So we did because of the hepatosplenomegaly, we are fortunate that we ordered for 4-5 tests and most of them came positive at the same time. So we are lucky to get some diagnosis. Most of the pediatricians, when you do these tests, we are not getting them positive. So we did a sickling test which was positive. His bone marrow was asked, it came as pus, and the bone marrow biopsy which came subsequently showed a necrotic findings that's normally seen in sickle cell disease or malignancy patient. His skeletal survey which we did showed multiple osteolytic lesion. Everyone knows the differential diagnosis, and bone scan later on also showed increased uptake. So now considering the diagnosis of sickle cell disease with osteomyelitis, Dr. Ira Shah, he was already on this antibiotics. Which antibiotics will you select considering the whole patient's history till now?
If we consider the diagnosis of osteomyelitis, this is a culture negative.
Sickle cell disease.
Yeah, he's a culture negative osteomyelitis. So it's not necessary that this is an infective osteomyelitis. So if this is infective osteomyelitis, normal causes of infective osteomyelitis are usually Staph aureus. In a sickle, you would consider Salmonella. We should not forget Kingella. So if I had to consider all these organisms and give an antibiotic, it would be something which would cover Staph, Kingella and Salmonella. So probably it would be a ceftriaxone vancomycin combination in this child.
So he's already on nearly 10 days of ceftriaxone.
But this is provided this is infective osteomyelitis. If I have a culture negative osteomyelitis, it could be
culture negative and all. See that you are at a facility where you may get cultures and all accurately grown, but pediatricians practicing in the periphery or even in Mumbai, you don't always have the facilities. So you will give treatment for any higher antibiotics other than ceftriaxone, or you will continue ceftriaxone and you add what other for
vancomycin.
staff? Vancomycin. So this you assume it is MRSA.
Probably.
But you got a culture of coagulase negative, so you are justified in starting vancomycin.
Probably.
So we started meropenem and vancomycin as the patient did not respond to 10 to 12 days of this thing. Patient had continued fever for another 9-10 days. Then we discussed the role of empiric fungal treatment. Obviously, he's not immunocompromised, not on long line, no neutropenia. But azithromycin as a combination for salmonella, we gave that, maybe irrational, so we've given azithromycin. And any further workup at this stage, Dr. Balasubramaniam? Because it's becoming slightly difficult to manage.
I don't know what we are dealing with. Definitely the workup. I mean, I'm going to re-examine the patient and do a workup for a PU. Basically, when you have a child like this with fever, when we have a child who has fever like this, when we have a child who has a fever like this, it's a PU.
Right.
And PU, common sense tells me that there are only 3 strong possibilities: infection, inflammation, and malignancy. These 3. And in India, I include tuberculosis, put it in the top of the list.
Yes.
Right? And added to this, I will think of an abnormal host behaving in an unusual manner with an usual infection. And I will work up based on that clinical data. Perhaps the first investigation, the cheapest investigation I would consider for this patient is a bone marrow aspiration, the bone marrow culture. Perhaps the other investigations, if I'm based on clinical grounds, I might do an imaging modality considering where the lesions are. Perhaps an MRI would definitely help, because I would know what type of osteomyelitis it is.
This patient had some neurological finding. We thought there may be abscess or something there. That was normal. He had old scars and all. Repeat X-ray of the tibia, which showed increasing size of the lesion. Osteomyelitis, once you see on X-ray, that means the lesion is at least for 10-14 days. He is going for chronic osteomyelitis. And MRI also showed osteomyelitis. So what factors will you consider? 2 or 3 important factors will you consider if patient is not responding to antibiotics? Dr. Ira Shah, give only 2 or 3.
This
so we'll
was
continue.
Focal.
As an infectious disease specialist, will have a long list.
He's my postgraduate teacher, so I think I'm sitting for an exam now.
Yeah.
So
important to whatever.
This osteomyelitis was only at the tibia, or was it?
It was multifocal, probably at all places.
Yeah, because you did a bone marrow. So bone marrow probably was ischial spine, so where you got pus.
Yeah.
So there was an ischial.
No,
so it's a disseminated multifocal osteomyelitis. So apart from.
So what are the factors
bacterial,
in general? Patient, the fever, you don't respond.
Yeah,
what do you
so
look
apart
for?
from bacterial, you would keep in mind multifocal TB. You would keep in
tuberculosis,
mind
histiocytosis.
So histiocytosis would also be one of the etiologies that you
fine.
take.
I think we will go ahead. Like Sir said, good clinical evaluation.
To me, the first diagnosis when I think of when my antibiotic is not working, the wrong diagnosis.
Pediatrician never agree to that.
I'm just saying.
Pardon?
Drug fever. Yeah, anything. It could be anything.
We'll come to that. So after this child is always irritable, he's difficult to examine. We examined the child. After a few days, he had some tenderness coming at the site of his tibial lesions. So they were swelling both sides. He was operated, drained. Orthopedic surgeons drained the osteomyelitis area. Patient improved after the drain. So always remember, foreign body or an abscess which is localized. The patient's diagnosis is made. If you rule out those things, always the patient may benefit. And we gave antibiotics for 4 weeks. He improved after that. And there is a role for chronic prolonged therapy in sickle cell disease with intracellular organisms like salmonella. So that is one point. And winding up this case, we gave him vaccines for pneumococci, meningococci, and typhoid as a case of sickle cell disease. And we gave him penicillin prophylaxis as per the guidelines. And patient was better in his discharge. So it's a complicated case. Yes, Ira, one last comment, whatever you want.
There's an entity known as a chronic recurrent multifocal osteomyelitis, which is a non-infective osteomyelitis, which can come as multifocal lesions and they actually just respond to NSAIDs. So they are culture negative osteomyelitis, which is what I was highlighting on this point. So that is one entity that we
microbiologists will be very happy that you rely on their cultures, but I'm not sure you can.
We've got microbiologists sitting in the audience, so they will.
I think it is very difficult for a pediatrician to not to give antibiotics, and that's a one possibility
so
to think of.
We would have to keep that in mind.
Okay, I think we'll go through the next case. We've a 2-year-old child who came first to us at 1 year of age with we diagnosed him with classical tuberculous meningitis, hydrocephalus. We started him on 4 drugs. Then we got a history that mother was diagnosed to have pulmonary tuberculosis. Child was around 4 months of age at that time. Mother was sputum positive. The MGIT drug sensitivity showed that she was resistant to streptomycin. So mother was single drug resistant TB, not MDR TB. The child was 4 months at that age. So Dr. Balasubramaniam, you will give chemoprophylaxis to the child if he was coming at that stage unaffected with any illness.
Now, you want to know whether you should give chemoprophylaxis.
If the mother came to you at that stage, the child 4 months of age.
Yeah. As per the recommendations, up to 6 years, definitely a contact, definitely INH.
INH.
So for 6 months is definitely indicated. And only thing now there have been controversies regarding the chemoprophylaxis for tuberculosis. Many regimens have been studied. Best regimen has been a combination of INH and rifampicin.
3 months.
For logistic reasons, the Indian Academy of Pediatrics, as well as the Government of India, has decided to go in only for INH alone. And even 3 months course of INH and rifampicin has been found to be as good as thing. The problem arises only when you have a contact with somebody who's got multi-drug resistant tuberculosis. The choices are many, starting from doing nothing and observing and giving drugs like quinolones, etc. But that's not the.
I think the better option Dr. Ira always mentions is not to do anything, just follow up the child closely.
Best course is to follow up, and surveillance is the best course of action.
Okay, this child's second admission after 4 months after treatment, he came with convulsions, hemiparesis, vomiting and fever. As usual, every time we go on repeating CTs as the TBMs come, LFTs was normal, CH showed mild pleocytosis, a VP shunt was done. So it is always difficult to rule out drug-resistant tuberculosis in a child. Diagnosis of resistant tuberculosis in children is essentially clinical and by conventional culture methods, which we all do, which is not always positive. So Dr. Ira Shah, which are the rapid tests which can be useful in diagnosis and treatment of drug-resistant tuberculosis? Briefly name them, the time taken, and some limitations, if any.
See, the gold standard is a culture. Now the culture is going to take 3 to 6 weeks depending on whether you're doing liquid media or solid media. If you want to test rapid diagnosis and you want a drug sensitivity pattern in say 24 hours or 48 hours, you need to do a PCR test. These PCR can be nucleic acid amplification test, that's your gene expert. You can do a line probe assay, which would give you even resistance pattern to second line drugs. The problem with these tests is that usually when I call up the lab and tell them I want an LPA or I want a gene expert, they say it's better if you have a smear which is 2+ AFP positive to do those to get the reliability of the test, because occasionally you could get them negative and you would still be left with nothing. And everything costs money here. So if I'm going to ask for a culture, which definitely I'm going to ask for, and plus I'm going to ask for an LPA or I'm going to ask for a PCR, gene expert, each thing is going to cost me money. So I need to prioritize which test I'm going to take. Recently I had a child where AFP was positive and I wanted a LPA. They said we put it for culture because out of the 3 sputum samples, only 1 had AFP. So we put that for culture. The other 2 are negative. We can't run an LPA on that. So if you need a LPA test, you need to be very careful what you're asking the lab for. PCR, gene expert, be very careful. Problem with these tests is if I do a gene expert, I'll get a rifampicin resistance. I don't know the resistance pattern of all the other drugs, especially the second line drugs. There's a poster outside on emerging second line drug resistance that we are seeing in Mumbai. So just knowing rifampicin resistance is not going to be enough. You would need to know resistance pattern to all the remaining drugs. That's why your culture and drug sensitivity.
Money is not the issue. Will you send these tests in all patients, or you will do only cultures and in selected cases you will send the rapid tests, sir?
I'm basically a socialist. If the patient can afford, we definitely nowadays ask for expert TB test, which costs around 2,000 rupees. You get a report very fast. one, and it helps you in situations where the smears are negative.
Yes.
And when you have a clinical diagnosis of tuberculosis, for example, tuberculosis meningitis, it helps you decide quickly. That's one. Two, what we do in Chennai, if patients cannot afford, we have a good tuberculosis research center, but they gave a report after the patient is sometime dead also, about 12 weeks, Lovins and Jensen, but the reliability is extremely good. It costs only 100 rupees. Somebody has to go on a weekday to get the bottles and come. These are the problem. If it's a poor patient, we base our decisions on clinical findings. We send it for a government center which is more reliable. For affordable patients, liquid media gives the report fast. I ask for it, and I ask for expert TB. And those who cannot afford to go to the...
Yeah, I think we have, in KM, we have started the gene expert. We are getting positive results even on gastric lavage with patients. So they've mentioned for CSF, gastric lavage, but less common in pleural fluid. So these are the other tests which we discussed. Now, Dr. Balasubramanian, will you continue the AKT in this patient or change or add second line drugs on the basis of the current whatever you have with the patient?
With the background of a mother having, I mean, I would like to know more details about the mother's treatment details.
She's completed treatment, only streptomycin, she's recovered.
She had resistance.
Only streptomycin resistance was there.
I don't know how reliable these resistance tests are nowadays.
So you will start second line drug?
Yeah, definitely. It's basically if the child has got a serious disease like tuberculosis meningitis, definitely I would go for second line treatment. Whereas if it is not a serious disease, I would reassess with the child's data.
So that's what we've done. In view of Dr. Ira, your answer?
Yeah, I would defer.
Wait, you'll wait probably.
I would wait because hydrocephalus is a known complication with TBMs, and it does not mean it's drug resistant.
Yes, but if he has fever and a bit of pleocytosis, and in view of patient's condition who's sick, and mother's history of course of only streptomycin, if he has fever and if he has pleocytosis, I know this will be, audience will be 50% split up between either way, so it's okay either way, so both of them are correct. So as per the mother's sensory pattern, we continued the 4 primary drugs, and we also added the 2 most potent drugs in the second line, that is amikacin and levofloxacin. TB, MGIT was sent and AKT was continued. 2 months later the report came in this patient, the sensory pattern was similar to the mother's. That means he was resistant only to streptomycin. So we, I don't know why, but we dropped amikacin thinking that it was streptomycin correlation. We decided because the patient was serious, he continued levoflox. Dr. Ira Shah, what is the cross-resistance seen with streptomycin and other aminoglycosides?
Usually if you get streptomycin resistance, you could still be sensitive to amikacin, kanamycin. And if you get resistance to amikacin, you would be cross-resistant to kanamycin. Capreomycin, though it's used as one of the aminoglycosides, it's hardly used in children. So if I go resistance-wise, streptomycin first, then capreomycin, then cana and amikacin together. So that's the way it will go.
Okay, the child again came to us a couple of months later with some convulsions and vomiting. We did a CT scan showing ring enhancing lesion, improved in 1 or 2 days, we discharged him. But the final admission was at 1 year, 10 months, where we repeated a CT where there was a tuberculosis abscess. So that abscess was drained by neurosurgeons who are normally reluctant, but this time they drained the abscess. And after removing the abscess, we sent that material for MGIT. The sensitivity from Hinduja showed no growth. Patient is discharged and doing well on the drugs. So he's taken 6 months of the 4 drugs, 5 drugs, and now he's on the other drugs. So briefly, the National Drought MDR control program mentions this line regimen as a regimen to be given to patients. Dr. Ira Shah, in absence of sensitivity report or pending such a report, how many drugs and which drugs will you prefer when you're starting second line therapy?
If I have decided to start second line therapy, then this combination is something that I would not go for, because if we see the resistance pattern that is there right now in the city of Mumbai, most of the drugs are resistant to pyrazinamide, ethionamide and levofloxacin. So probably I would land up giving this child only kanamycin, ethionamide and cycloserine, 2 drugs to which he is sensitive. So ideally, if you're going to start second line, make sure you're going to get resistance pattern for all the 13 drugs that you're asking for. Secondly, it would depend, the choice of second line drug would depend on where is the TB. If it's CNS TB, your choice of drugs would be different. You want drugs that penetrate into the CNS. If it's somewhere else, you want a different line of therapy. So it would be pretty individualized. And that's the problem that's occurring with patients.
So if you were to give 6 drugs, you select the 6 drugs?
It would depend on the organ system.
No, CNS, suppose 6 drugs CNS.
This child I don't think is drug resistant.
No, forget this child, CNS, he's not responding. 6 drugs, you give your 6 drugs first.
Yeah, so you would have an aminoglycoside.
Which one? Canamycin.
You could use canamycin,
Okay,
amic acid. I would be a little skeptical about the quinolones, but if I had to add a quinolone, it would be one of the highest generations, so it would be moxifloxacin.
Oh.
I would add cycloserine. I would have pass in this child actually, and probably I would go on to a 5th agent, which would be something like clarithromycin.
Okay, fine. Just briefly, sir, any major problems you face while giving second-line drugs? You must, anyone can.
One
answer.
is compliance. You really need compliance because you're giving more than around 20-30 pills a day. Cost is another issue because you're going to go up to 6,000 to 10,000 rupees a month. Getting an aminoglycoside.
The biggest problem I face is in understanding the regimen and deciding the drug dosage and monitoring the child. So it's a big problem. You have to do cultures every month to follow the child meticulously. In fact, we take help from Tuberculosis Research Center, fortunately.
So now, just for the audience, we want to know the what are the your personal and current literature in India among MDR, that is resistant to INH and rifampicin, new cases and retreatment cases. What are the percentage of MDR cases?
See, whatever literature we have in India is actually based on adult studies. At Wadia, we've crossed over 100 patients who've been diagnosed as MDR TB. And most of them are actually in contact with an adult who's had drug-resistant TB.
So there are new cases?
There are new cases. Very few would be, or 50% would be somebody who's been treated for TB in the past 2 years.
Okay, what is the outcome of such patients? You manage MDR TB patients?
If they are, right now we have around 6 patients with XDR TB. But XDR doesn't do very well, but MDR, most of them come out.
So you have to say anything on this?
Actually, we published an Indian Journal of Microbiology along with Shankar Netrala. We had a series of 18 cases in which we could detect MDR TB. Surprisingly, 12 of these patients did well with conventional therapy, though they were reported to be resistant to INH and rifampicin. It was done in a pretty good lab. But 6 died in spite of good treatment. We realized it very late. They didn't come for follow-up. Treatment compliance was very poor. That's the data we have. But by and large, this problem is as such in pediatrics is not so big like in adults, but it's going to become more difficult in future.
I think winding up, I think time is over. Dr. Ira doesn't agree with this diagnosis of MDR. So if it was something like an iris, so without HIV positive,
no, you had
how will
this
you
child
manage?
Who had TBM first, then he comes back with a hydrocephalus, then he comes back with a tuberculoma, and then he comes back with a tubercular abscess. You've grown TB once, and that has shown sensitivity to all except streptomycin. The second time when you had an abscess, you didn't grow anything on culture. So this is something, if he keeps on getting, it's kind of a paradoxical reaction like what you said as immune reconstitution, where you got tuberculomas coming up. So it's kind of an immune reconstitution syndrome, but you don't get an abscess with immune reconstitution. So if I'm getting this recurrent TB infection persisting in a child who has got a sensitive pattern, there is an immunodeficiency state known as Mendelian susceptibility to mycobacterial diseases, MSMD, which should be kept in this mind. So I should look at the interferon IL-12 receptors and see if there's any problem there. And probably in this child, then the duration of treatment would be much longer. It won't be standard 12 months. It would be a much longer treatment.
So will you give steroids? Now suppose those tests are not available. You consider iris. Will you give steroids in this patient?
If those tuberculomas are causing raised ICT, or if those...
No, not raised ICT, just for the...
No, if the child is not symptomatic, no.
And I think shortage of time is there. We've completed most part of the second case also. Thank the expert.
That was a very interesting session.